Pleasure that I introduce the first presentation for today, which is the High Intensity Treatment Program. We'll call it the HIT program as it's commonly known in South Australia. Today's presentation will be delivered by three people involved in the HIT program in South Australia. Firstly, Dr. Stacey McCallum, who is a clinical psychologist and has worked in corrections in South Australia for 6 years, and Stacey's currently managing the HIT program. Joining Stacey is Dr. Ben Stewart, who is also a clinical psychologist. Ben has worked for corrections in South Australia for 7 years and is also working as a clinician in the HIT program. And joining those two is Sheena McMullen. Sheena's worked for corrections in South Australia for about 15 years in various custodial and community corrections case management roles. And more recently, Sheena has worked as a case manager in the HIT program. So it's my pleasure. I'll hand over to those three. Thank you.
Thank you, everyone. And just like to introduce myself, I'm Stacey McCallum. And to this side, I've got Ben Stewart, and to this side, Sheena McMullen. We'll be asking to move on to the next slide, please. So today, what we would like to cover is to provide a bit of background initially on post-sentence supervision orders in South Australia. And then I'll be providing a bit of information about the high intensity treatment program and the inception of that program and rollout of the program. Towards the end of the presentation, Ben will provide a snapshot of what a day in the life of a clinician role in the HIT program looks like. And then that will be followed by Sheena providing a snapshot of what a day in the life of a HIT program manager looks like. And we'll be finishing with some question and answers at the end. Next slide, please. So post-sentence supervision orders in South Australia were introduced the legislation was introduced in 2015, but we didn't see its implementation until roughly 2016. This legislation was introduced in order to provide further supervision for offenders who were considered to be an appreciable risk to community on release, particularly sexual and violent offenders. And it was in response to people who were in prison and who were potentially not participating in rehabilitation programs, not applying for parole and sort of choosing to do their full sentence in custody and then being released with no supervision in community. So the extended supervision order legislation in its execution is comparable. It looks like a parole order, in which we have the Parole Board of South Australia that oversees the compliance of those orders in community, and breaches of the conditions of the extended supervision order generally will result in a return to custody for a period of time. Now, this legislation was implemented and it was thought in South Australia that we would have roughly about 10 people that might be subject to that legislation at any given time. However, what we noticed quite quickly was that we had far more people meeting the criteria of the legislation and far more, a large number of people being subject to these orders that were determined by the Supreme Court. So currently we've got anywhere between 130 and 150 people on extended supervision orders in South Australia, which is quite high. I think we have a comparable number of extended supervision orders to New South Wales, but obviously very different population sizes. So not only was the number of people being subject to these orders very much higher than what we had anticipated, We're also seeing that the breach rate for the cohort was really high, and people were returning to custody quite quickly, and were spending a lot of their time not in community, but in custody. Next slide, please. The HIT program, which stands for High Intensity Treatment Program, was a concept that was developed through some key people within the department, and I'll speak about the HIT program in a bit more detail next. But I just wanted to touch on forensic assertive community treatment as a model, which is really what underpins what the high intensity treatment program is. So forensic assertive community treatment is an adaptation of assertive community treatment. You typically see assertive community treatment models being implemented in a number of different areas, such as in health-related areas, or generally with people who present at high risk. We have seen a forensic adaptation of assertive community treatment in the last 15 years. And typically those cohorts are people with serious mental illness who are engaged with the criminal justice system. What forensic assertive community treatment does is tries to work with really complex need clients in a way that's quite client focused, that's based in community, where there's outreach and lots of time working with clients within their own environment, generally working with them in a time unlimited way and working with them in a multidisciplinary way. So we chose forensic assertive community treatment to underpin the high intensity treatment program, and we use the literature, which our acknowledging is quite limited in terms of the research of its application, but we have seen some promising outcomes, both in regards to criminogenic outcomes and mental health and psychosocial outcomes in Belgium and also in New York State in USA. Next slide, please. So in 2021, this year, the Department for Corrections in South Australia received funding to pilot a new program to see whether or not we could work differently with clients who are subject to extended supervision orders to try and change that pattern that we were seeing in terms of the number of people who were being subject to orders, but also the breach rate being so high. So the high intensity treatment program was initially an idea amongst some key staff in the department. However, in 2021, myself as the program manager started in January and started to build what the program would look like in terms of its operation. The HIT program, because it's a pilot, we don't work with the entire extended supervision order cohort, as I said, around 130 to 150, but we're working with a small proportion of that cohort, and that is anywhere or no more than 30 clients at any given time. So we're very selective in which clients that we accept into the program, and we're generally looking at those complex needs, which Ben will walk through a bit more in a moment. The HIT program is a pilot that will run for about 12 to 18 months and include some evaluation. So we do have an evaluation framework with an interim evaluation happening in February next year, and then again at the end of next year. The HIT program is really the first of its kind in Australia. Although we're using that forensic assertive community treatment framework, there's nothing that's been done like this that we can find elsewhere in Australia or even around the world. But as I mentioned before, we do have some evidence to show that similar programs have been effective overseas. Next slide, please, and I'll just hand over to Ben to walk through the next component.
Okay, so in terms of the staffing structure, the HIT program does fall under community corrections. Although, as we'll kind of be covering, we do try and work both in community and in custody with our clients. Tony Shillabere, our Regional Director for North, has kind of operational oversight and line management over the program. And then Stacey is the HIT Program Manager, and she receives kind of clinical support and supervision from the Director of Offender Rehabilitation Services, Henry Faru. Then within our team, we have the 3 HIT Program Case Managers, 1 HIT Program Aboriginal Specialist, and that's kind of recognising that providing a really culturally relevant and appropriate service to our clients is really critical to engaging them in a way that's going to be successful, and acknowledging the fact that within the ESO cohort, Aboriginal offenders are overrepresented. Now, the next kind of staff members are the HIT program clinicians, one of which is me, and then we also have a social worker, Kylie, and then we also have a research and admin officer. Next slide, thanks. So our program's aiming to address the really complex needs of individuals subjected to ISOs and ESOs in the community and in custody. And as Stacey mentioned, what they were finding in South Australia with people under extended supervision orders was that they were breaching frequently, breaching quickly, and being returned to custody quickly. So very little time spent in the community, and because of that disruption, very little ability to be able to engage in meaningful intervention and rehabilitation. So people weren't getting those criminogenic needs addressed. And for many of them, custody isn't a deterrent. So we weren't really seeing any behavioural change. We're just seeing people being returned to custody. So we're trying to do things quite differently to kind of, I guess, the treatment as usual or corrections practice as usual. So what we're aiming to do is ultimately really reduce the time spent in custody, but in a way which is still maintaining community safety. So if we can reduce the rate of breaches and improve the compliance with the orders, and doing so in a safely way, then that will reduce time spent in custody. But we're also trying to have a bit of a different approach to offenders when they are breaching, in that trying to hold them in community longer, but address the risk that might be presenting if they are engaging in behaviours that are breaching their order. So the typical one is around substance use. And so what we're trying to do is, instead of just return to custody as a bit of a knee-jerk reaction, we're trying to address that substance use in a really intensive way. And so often our offenders might have a number of barriers which are preventing them from meaningfully engaging in, for example, substance use treatment when they're in the community. With our staffing model and the ability to work with a small number of clients in a really intensive way, we're able to meet clients in the community or in their kind of environments in their home or near their home, and hopefully kind of reduce those barriers and give them the intensity of treatment that they require to prevent them reoffending and prevent them breaching in the future. As I mentioned, we're working with people both in community and in custody. And when people are returned to custody, there's often a real disruption in many things in their life, such as housing, the substance use treatment, mental health treatment, or participation in programs or one-on-one therapy that's addressing their offending. So when we're able to bridge that gap and work with them between custody and community, we can ensure that there's a continuity of care in terms of that treatment, but we can also be, I guess, coordinating different services and trying to minimise that disruption and ensure that there's a smoother transition between custody and community. So that does involve kind of collaborating with different organisations, both within DCS custody and community different units, as well as mental health systems, forensic mental health systems, and different services they might be accessing around their substance use or housing. Ultimately, we also want to try and reduce reoffending through addressing the risk factors that are associated both with their offending as well as them breaching, which usually there is quite a bit of overlap. Some of our kind of secondary aims, which kind of feed into those primary objectives that I was just speaking about a little bit, are around some of those maybe more psychosocial kind of factors. So reducing severity of symptoms, whether that's around drug use or mental health, improving people's functioning in the community and their quality of life, improving their relationships with partners and families and their support networks, integrating them more into the community, improving people's motivation to change and readiness for treatment, and insight into their behaviour too. So some of those are quite closely linked with those primary objectives, and some of them are more indirectly. We have a really strong focus in this team around relationships and building strong relationships with our clients. And often that might involve things that are quite distantly maybe related to their offending. But the thinking behind that is that by having improvements in their life in that way and helping them in their life with that way and improving our relationship with them, we can use that as a leverage for change in other kinds of areas that might be more closely related to their offending. Next slide, thanks. So in terms of the cohort that we're working with in the HIT team, we started out with all of the offenders that were under interim supervision orders or extended supervision orders. We had to remove people that were in non-metro areas, unfortunately, just due to the logistical challenges that would be involved in trying to be able to work intensively and assertively with people if they were too far away. We removed a number of people at that second point because they were actually doing quite well with corrections practice as normal. One person was removed because they had a continuing detention order applied to them, which means that they were going to be in custody for a significant period of time. At that point, it was opened up to kind of nominations from various people who I'll speak to in a second. So some people within that cohort weren't nominated, and of the ones that were, there's a HIT referral panel that reviews all the referrals that come through, and so they went through those pretty comprehensively and identified a number of people who wouldn't be suitable and removed those, and we ended up with a starting point of 28, but I believe we're at 30 now. Next slide, thanks. So in terms of the referral process, the referrals come from 3 different areas. So one being the Serious Offender Committee, the second being the Parole Board of South Australia, and the third being Community Corrections. So clients can be referred while they're in custody, prior to release on an order, or once they're in the community and already being managed on their order. Recommendations for referrals are reviewed and tabled to the referral review panel for consideration. It's a pretty robust kind of procedure for going through those. Next slide, thanks. So to be eligible for the HIT program, as I mentioned, the clients need to be residing or planning to reside on release in the Metro Adelaide area. As I also mentioned, Aboriginal offenders are overrepresented in the extended supervision order cohort. So we prioritise those offenders for inclusion in the program. We really want clients with complex comorbid problems and high service needs. And often that means a significant degree of functional impairment or disability in terms of their ability to kind of manage in the community and not just complying with their order, but also to manage the everyday kind of daily activities that they need to just live successfully and have a good quality of life as well. So clients who are considered by the referral review panel as unwilling or unable to comply with the requirements of the program are considered not suitable. And those would be those people that were screened out at the last step on the previous slide. And can I just get the next slide? Thank you. So of our current cohort, we have 28 male clients. Oh, sorry, this is Sheena. I'll pass over to Sheena now.
Yeah, so this slide gives you a snapshot of the current client cohort that comes under the HIT team. So obviously the large population is male clients with 2 female clients. We do try and target the Aboriginal population, and that's in line with the department's current strategical direction. So providing a service to Aboriginal people who are highly represented. The average age of the clients currently is 39 years old, and there's 6 clients currently in custody and 24 in the community. So obviously the goal of the program is to keep as many in the community as possible for as long as possible without returns to custody for, I guess, menial breaches, and only really returning when that risk is, you know, massively increasing in the community. The program does offer outreach and in-reach service. So whether a client is in the community or in custody, the case manager and the clinician and the Aboriginal specialist continue to work with the client and follow them and provide that through care between custody and community. This is obviously something our ESO cohort lacks in normally, because the constant returns to custody, as Ben touched upon, breaks their opportunities to continue to engage in intervention or rehabilitation, or any protective factors that have been built. Things like secure accommodation may then be lost, and it's kind of like starting the whole process over again. So we've found that this through care approach in this intense manner certainly is valued by the client, but also is providing really good results in the program. The program targets the complex needs of these clients who have quite often missed out on being able to be provided with intervention and being able to engage in opportunities to address their criminogenic needs because of their complexities. So if they don't quite fit or tick the boxes for group programs, both in custody or within the community, then they've missed out on a lot of intervention, or if they've had the opportunity to engage, they've been returned to custody and then not been able to complete any sustained rehabilitation programs. So the HIT team is about really unpacking these complexities for the individual and looking at how can we think outside the square and really try and use a person-centric approach to provide a service to these clients where perhaps, you know, mainstream services offered have not worked, or they've not been provided with the opportunity. Next slide. So the HIT program do a really high level of program planning for each individual client. So within community corrections, case plans are developed normally by a community corrections officer in conjunction with the client themselves. With the HIT program, we're very fortunate to have a multidisciplinary team that we use the whole entire team to contribute to developing a really individualised program plan for the client in conjunction with the client. Because of the small numbers on the program, each clinician and case manager is really able to get to know the client extremely well, and as a group we look at all the collateral information, assessments on file, and then we use every single person in the team's expertise and experience as well, with the client's focus and personal goals in mind, to develop a plan that is specifically tailored to them, but is also very dynamic and continuously reviewed and adapted as the client continues through their order. So certain things we might look at are, what are the factors that contribute to the client reoffending? What contribute to the client breaching their order? What the client's individual goals are. We also really have at the forefront of our minds is, what are the parole board's expectations? What's the AGD's expectations, the core and the community's expectations of the client being subject to this order? And that is always at the forefront of our mind when we're analysing risk and assessing risk continually. We look at strengths and protective factors that the client has and what we can continue to develop. We look at how we can continue with their participation in the program through both custody and community. So we have goals aligned for the event that if they are returned to custody, how we're going to continue their rehabilitation intervention and still continue to motivate the client to engage in the program, as well as specific goals for when they're in the community. We look at specific treatment targets for each client and how we can meet these needs, as mentioned before, thinking outside the square and specifically trying to tailor to the client. We also look at working with the client's families and really developing relationships with positive support people within their lives, so that we can actually have a wider team approach to support the client. And we also look at, you know, when the client will be exited from the program, what kind of time frame that may be occurring in. So it is a very team-orientated approach and a very detailed approach to developing these individualised program plans. And as mentioned, it's very dynamic and is constantly reviewed for each client. Next slide, thank you. So this infographic here basically shows how the team operates. And as you can see, everything is overlapping, and we have the client right in the middle and at the centre of the program. The client then is supported by the HIT program Aboriginal specialist, the HIT program clinician, their assigned case manager, and there are overlapping tasks that are combined between each staff member assigned to that client. But also in conjunction with that, we're constantly being overseen and liaising with our program manager, as well as the wider team. So even if as a case manager, I'm not specifically assigned a client, I will be contributing, assessing and supporting other case managers with their clients, because it is very much a team approach. And as we said, there is a really dynamic and diverse range of experiences within the team, so that we really all contribute to every client, not just the ones that we're assigned to. The HIT case manager and the assigned HIT clinician usually work very closely together as well, and are constantly in, I guess, collaboration about the client and talking about their treatment, and also any crisis and events that are going on for the client. So that's probably unique to the program, whereas normally in DCS, we kind of work in isolation from our clinicians in our rehabilitation programs branch and the case managers in the community. So we're very fortunate to have this constant communication between our clinicians and Aboriginal specialists to constantly be reviewing and supporting the client as best we can. So it's a very much a team approach, and quite often an overlapping and contributing to the client, whether they're assigned to you or just part of the program. Next slide.
So just touching on some further reading, if you're interested in the forensic assertive community treatment model, the studies are generally the ones that I've mentioned through the US or through Belgium. And like we have seen in the literature, not just an improvement in clients' quality of life, clients' well-being, we're also seeing some reduction in their risk of reoffending, and so those criminogenic outcomes are also being quite promising within the literature. I'll just use this moment as well just to talk, before I hand over back to Sheena and Ben to talk a bit more about their individual roles, just some differences with the forensic assertive community treatment literature and the HIP program and what we're doing. So one of the fundamental sort of focuses of this FACT research is that they're generally working with clients who have been determined or deemed mentally unfit due to mental illness. And so they're generally working with clients who have been given a license within a medical or a psychiatric facility rather than a custodial sentence. And so for those of you who might be familiar with those sorts of cohorts, generally really high prevalence of people with schizophrenia, bipolar disorder, other sort of mental illnesses, depression, but generally, yeah, sort of psychotic illnesses. And generally in the research, you'll see that the forensic assertive community treatment has been successful with those cohorts, and you'll see that they've actually excluded people with personality disorders. That's quite different to the cohort that we have. We do have people with those psychotic illnesses and schizophrenia, but we also have a really, really high prevalence of borderline personality disorder and, as you would be aware, antisocial personality disorder. So that's quite a key difference in the literature between forensic assertive community treatment and our adaptation. The other key component to mention about the HIP program, as dissimilar to forensic assertive community treatment approaches, is that we are really have quite a specific focus on providing a culturally specific service for our Aboriginal clients in the program. So as you would have seen in the slides previously, of our 30 clients, I think as of today, roughly 13 or 14 are Aboriginal. And that's where the Aboriginal specialist in the team really works quite closely with those clients, but also with the case managers and clinicians that might also be working with those clients in order to try and develop a service model that is specific to their cultural needs. So in a lot of our program plans that Sheena has been discussing for our Aboriginal clients, we are really trying to work with families around trying to reconcile clients with their families. We've seen, you know, most of our clients spend most of their life in prison. They do not have a sense of community or do not have that role within their families anymore. And so we'll see quite a lot of the goals for our Aboriginal clients will look different to the goals that we've identified. And that's through the input of the Aboriginal specialist. That's another component of the HIP program, which is quite dissimilar to what you'd read in the research. But fundamentally, the HIP program does use those forensic assertive community treatment approaches to working with clients. So I'll just ask to skip over to the next slide, and Ben will just provide quite a snapshot of what a typical day would look like for a clinician in the HIP program team, acknowledging that each day is very different, but just to give you a real sense of the work that we're doing in the program. So over to you, Ben.
So the work can vary quite widely because our clients are quite diverse in their presentations and in their needs. So I mean, I guess the foundation of the work that we do is cognitive and behavioural therapy based, in that whether it's in relation to their offending or in relation to factors around mental health, we're trying to address thinking patterns attitudes and beliefs that might be maintaining problems in those areas, and they're offending or they're breaching. And we're trying to address maladaptive behaviours which might be either contributing to their offending or are actually offending in of themselves. So this needs to really be tailored to the clients and their individual kind of presentation, as I kind of just spoke about, in terms of we have clients with acquired brain injury and intellectual disability, or difficulties associated with that, with memory and concentration, where we might really need to scale it quite back. And then we have clients who are reasonably quite well functioning in terms of their cognition, but have other problems that might be really driving it in terms of their mental health, and emotional regulation and impulsivity are probably quite important ones. So in terms of the presentations, a lot of the work that I do is around personality disorder traits, which, as Stacey mentioned, really distinguishes us from some of the other fact literature. So in terms of addressing those needs, we are running a modified dialectical behaviour therapy group on Mondays with some of our clients who present with traits of borderline personality disorder. So the key kind of targets that we're trying to address there are probably problems with distress tolerance and emotional regulation, as well as impulsivity. And then some of their kind of interpersonal skills too. And mindfulness is probably the consistent underlying factor in the treatment there too. In some of my individual work, I use an approach called Schema Therapy, which I thought might be new to people, and so I'll talk to a little bit before I hand over. So Schema Therapy is an approach for people with long-standing chronic problems, particularly personality disorders. And it's based on the premise that all humans, and from childhood through to adulthood, have core emotional needs, such as the need for kind of safety, physical safety, as well as emotional security, being heard and understood and validated, the need for spontaneity and fun and joy, as well as the need for kind of boundaries and limits. So our clients, due to traumatic backgrounds and other adverse childhood experiences, haven't had these core emotional needs being met, and that leads to the development of what we call schemas. Schemas are basically ideas about the world, themselves and other people that are maladaptive. They're associated with strong kind of emotional response when they get triggered in everyday situations. And they're really tied in with childhood kind of memories of where those schemas get developed. And then in later adult life, those schemas are really entrenched. And when they get triggered in everyday situations, our clients will kind of what we call flip or switch into certain modes of being. So that could be involving a lot of anger, or it could involve detaching, or it could involve using drugs and alcohol or other kind of addictive behaviours to avoid emotions. And we call those either kind of emotional based modes, coping modes, or overcompensatory modes. And some of these modes are really quite strongly linked with offending behaviour, particularly the ones that might be around uncontrolled anger or impulsivity, and modes that might be overcompensatory in terms of being cunning and manipulative or preying on others. Now, in the schema therapy approach, there's a cognitive and a behavioural component in terms of trying to help the client understand that when they're in these situations and being triggered, and they're having certain thinking patterns which are unhealthy, that's kind of the schema which is driving that, and getting them to think in a different way, getting them to behave in a different way. So that's kind of that traditional cognitive behavioural approach. Schema therapy goes a little bit further though, in recognising that these schemas and these modes that people are going into have their basis in traumatic or other kind of stressful experiences from childhood, which continue to have a really powerful effect today. And so we do some what we call experiential exercises to try and I guess, heal those kinds of wounds and to reduce the intensity of those schemas and the intensity of those modes when they come out. So some of those experiential techniques include imagery rescripting, where I'll get a client to imagine themselves back in a traumatic childhood experience, and we'll go through the image and pause it at the point at which it's the trauma is about to kind of occur, and we rescript how that kind of plays out, and we use a technique called limited reparenting. So many of our clients haven't had those emotional needs met, as I said, by parents or caregivers that were there, and so it's up to the therapist to be entering that image and to be reparenting or having the client get those emotional needs met. Eventually, the client, through that modelling, is able to do that for themselves. And one of the other experiential techniques we use is mode work or chair work, where we engage the client in dialogues which between the different parts or modes that I talked about earlier. And we put those in chairs. And I'm sure this sounds really strange to people, but we put them in chairs and they engage in a dialogue, and people build up an awareness of those different parts in themselves. And through mindful awareness of that, they're able to not engage in those modes so automatically. And they can choose to respond in a healthier kind of way, which is initially modelled by the therapist, but eventually strengthened in the client themselves. As I said, this all probably sounds pretty odd, which is why I wanted to kind of speak to it, because I thought it might be something novel to people who might be watching today. But it isn't just kind of snake oil. There's a really strong research basis for schema therapy with people with personality disorders, including in forensic populations as well. So it's strange, but it works. And I think we've been seeing some pretty good results for people in our program with that kind of approach, as well as, I guess, the whole of team approach and the work that the case managers are doing, that the Aboriginal specialist is doing, and that they're getting in our DBT group as well. So yeah, that's a little bit of a snapshot of kind of what I do.
Thanks, Ben. We'll just move on to the next slide, and Sheena will provide you an overview of a typical day for a case manager in the HIT program.
So as Ben and Stacey have both said, each day can be quite diverse, and working with such a complex cohort, each day can sometimes unfold differently as to how you plan. So you really have to I guess, be resilient and willing to work in a very dynamic and responsive fashion, and be very flexible into meeting the needs of the client on a day-to-day basis. As a case manager, we not only perform normal case manager duties, I guess, of what a case manager would do in community corrections, of things like conducting drug tests, writing reports, reporting to the parole board, attending parole board interviews with the client, and conducting supervision. But supervision, it looks very different in the HIT program. So supervision may occur within a community corrections centre, but it can also occur in other locations. So quite often, we have to roll with resistance, and so it may be that if a client's contacting me to say that they can't come into their appointment today, or a crisis is unfolding, that then it may be that I then go out to the client, or perhaps go and meet the client somewhere. On occasion, both Ben and I have dropped everything and responded to a client in crisis and gone out to the client's home together, and also worked with other agencies like SAPOL to try and manage a crisis situation where risk was escalating, and normally a case manager wouldn't be able to do that and have the support of a clinician where you've both got an excellent rapport with that client, and then able to support SAPOL in de-escalating a situation that ended up resulting in the client not being breached and staying in the community, and keeping the community safe as well. So being able to respond in that manner is certainly a really rewarding part of the role, and is also a part of the role that normally maybe wouldn't be able to occur on a day-to-day basis in community corrections. One of the things that we do through our supervision is we're supporting the work that the clinician is doing with the client. So normally in community corrections, if a client is doing a program with a clinician through the rehabilitation program branch, the case manager will get a post-treatment summary, and we'll do a handover at the end of the client's participation in that program. In the HIT program, we're constantly reinforcing and working with the client to build upon the work that the clinician's doing with the client. So each week in supervision, if Ben's worked with one of my clients, I may have a discussion with Ben about what some of the key focuses of their work was that week. And then in my interactions with the client, I may be asking them to recap some of the things that they'd learned, how it's related to them, maybe some looking at some opportunities where they're able to implement some of the skills and strategies that Ben has been working with them on, or looking at perhaps some events that have occurred throughout the week where they haven't used those skills, but could identify that perhaps implementing those skills may have provided a different outcome for them. So we're constantly looking at opportunities to positively reinforce when they are developing and using skills and strategies that the clinician is working with them on, but also trying to support them in providing opportunities to identify where, you know, perhaps utilising or changing behaviours and utilising some of these skills could actually make a difference in their life as well and provide different outcomes for them. So I find that really rewarding, and I'm also able to, because of my consistent contact with my clients, do brief interventions, which is we have the time to really sit with the client and conduct those brief interventions. Obviously, always doing motivational interviewing with the client to try and keep them on the right track and also engaged in the program and the intervention that's occurring for them. Due to the consistent contact with the client and really being able to build rapport and get to know the client very well, we're able to do constant risk assessments. So in the team, we've all been trained in the Drear assessment, which is an assessment tool for clients in the community, where we're assessing dynamic risk of the client. And we're utilising this assessment tool regularly. So sometimes every sort of fortnight, or sometimes every contact that you're having with the client, we use that tool to really identify risk, protective factors, and whether that risk is acutely increasing in the community. We also liaise with other agencies a lot as a case manager. So I have clients who are under the NDIS planning, and will quite often be liaising with their support coordinators or their support workers, also liaising with agencies like SAPOL, housing, mental health, and really providing and leading that wraparound response to the client. Quite often we will call case conferences and bring in other agencies to ensure that we're all working together to support the client, and we really take ownership of taking the lead quite often to pull all these agencies together and respond to what the client's needs are at that specific time. I've had the opportunity to attend appointments with the clients, and this has been really positive, because quite often these clients can be overwhelmed, dysfunctional or disorganised in attending key appointments, and to have someone really, you know, the case manager prompting them to come to the appointment, organising to ensure that they can get to the appointment and supporting them at these key appointments has really made a massive difference in the level of care and providing, I guess, towards the client's needs. So being able to do that has been a really key factor in seeing some significant progress for our clients. We work very dynamically and remotely. So quite often I may be working from a different community corrections office. And like we said, going out doing home visits or working with the client in the community, meeting them in public places is a key component of the responsive and intensive manner in which we're working with these clients. And just always having that consistent contact with the client, which is in line with the department's thinking around that every contact matters. And I believe the HIT program really supports that view of every contact with the client, whether it's via phone, face-to-face, in different environments, is extremely important and valuable and is always contributing to the rehabilitation and meeting the criminogenic needs of the client.
Thanks, Sheena. Just before we start to think about question and answers, I just wanted to also speak about the role of the Aboriginal specialist in the HIT program who isn't unable to join us today. The Aboriginal specialist is allocated to work with the Aboriginal clients in the HIT program, and as already mentioned, we do see an overrepresentation of Aboriginal people subject to extended supervision orders. So we're very motivated to include Aboriginal clients in our program because they do receive that special contact with the Aboriginal specialist in the team. The Aboriginal specialist does develop a different relationship with clients, probably compared to what the case manager and the clinician might develop. And the Aboriginal specialist will be really trying to build an understanding of that client and their family, but what their cultural needs are. So the Aboriginal specialist does have a document which they put together specific to each Aboriginal client, which really looks at their cultural background, their relationship with culture, their knowledge, their understanding, their motivation to increase their connection with culture. And all of this is considered to be a form of rehabilitation. A lot of our Aboriginal clients are disconnected from culture, and most don't have a strong sense of culture. And so the Aboriginal specialist tries to understand where they're at and tries to outline a path for increasing their connectedness to culture as a form of rehabilitation. So one of the key roles of the Aboriginal specialist, which has been really quite critical for our Aboriginal clients, has been the introduction and rollout of the Yarning Circle program. So Yarning Circle runs on a Friday, and it occurs at our Living Ghana Cultural Centre, which is in the sort of outer suburbs of Adelaide. And that's a space where Aboriginal clients in the HIT program, if they are in community, are going to receive contact with other Aboriginal clients who are on the HIT program with the Aboriginal specialist. The Yarning Circle program is essentially developed by the clients themselves. They're determining the topics that they wish to discuss, and it's generally based on what's occurred for them within the last week. And it's an opportunity for all of them to be able to discuss issues that are important to them around people that have walked similar shoes. And I think what has been really successful about the Yarning Circle program is that it, through that connectedness amongst the Aboriginal clients on the HIT program, there has been this ability to be able to, I suppose, shift some of that being stuck in the unfairness of being subject to an extended supervision order, which can be really difficult to work with. People get stuck in just that anger and that anti-system mindset, which ends up just becoming something that then is really hard to work with, and it sees people on a progression to getting another order or spending a lot of time in custody. So I think through those relationships that the Aboriginal clients are developing with each other, they're able to see that, hey, there's other people, other Aboriginal people who are also in the same position that I'm in, and hey, I can see this guy's actually doing really well, and I'm gonna be motivated by that. And there's that sort of that impact that they can have on each other, which I think we've been able to see a shift in people's attitude and some motivation to change and to see out the order and to not return to custody. So that's been a really critical component of the Aboriginal specialist's role, is that yarning circle program, in addition to that cultural conceptualization that's occurring and that contribution to the multidisciplinary team, in order to ensure that we're actually providing a service for our Aboriginal clients that meets their needs. Also, just before we go on to question and answers, just wanted to reiterate the in reach that we do provide in custody. Now, it probably hasn't rolled out as smoothly as I had hoped, and that's probably due to a few things. So the idea of the high intensity treatment program is all that work that we've discussed and that Ben and Sheena have outlined. The idea is that regardless of whether or not the client is in community or custody, if they return to custody, they still engage in our service, and they still are able to be working on things, whether it's in therapy or through supervision or what, in order to be working on their goals for their participation in the HIT program. It's not as easy as that. We do try to make quick contact with clients when they are returned to custody. Sometimes people are returned to custody and we're aware and it's quite soon. Other people may be AWOL for quite a period of time, and there might be a bit of a gap between when they're picked up and returned to custody. But as much as possible, we do try and have that contact with them as soon as they're coming back into custody. With our metropolitan institutions, there are some challenges with providing a therapeutic service and having regular access to people in custody. We do have people moving quite quickly from institution to institution. We have some limitations in terms of times that we can access people when they might be going through that progression through institutions. We're also challenged by the fact that the institutional space isn't therapeutic, and so often that work that they might be working on in community is not able to be continued in custody because they become the custody version of themselves, where they are focused on what the custody version of themselves is, which might be the associates that they're associating with. It might be, you know, a form of safety. It's not generally a therapeutic or a rehabilitative environment that we're working with people in custody. We've also experienced just some real challenges with actually having consistent access, and that's through just some changes that are going through our prisons in the metropolitan area in terms of appointments being regularly cancelled. So it's not an uncommon experience for, say, Ben to rock up at one of the institutions and have, you know, a morning of clients booked and all those visits be cancelled, at the last minute. So that's still a component of the program that we still really need to work on, and that is, some of that's out of our control, but a really key part of the program that we think is helpful for clients when they are getting that consistent, that continuity of relationship. They're still getting that same person that they're working with, continuing to work with them in custody, but also acknowledging that, yeah, there are, you know, other things that we can be doing in the background while someone is in custody, which might not be actually face-to-face contact, like reviewing their NDIS plan, like maybe getting them to a prison that's more conducive to their rehabilitation needs, might be getting them involved in a program in community or custody. So we can do a lot of stuff in the background as well. So that brings us to the end of our presentation. We're about 5 minutes early, but I know we've got 15 minutes set aside for question and answers, and hopeful that we might be able to fill the extra 5 minutes with some more questions. So our contact details are up just there on that last slide. If you have any more questions or want any of the information that we've provided today, please don't be shy and get in contact, because we'd love to hear and be able to share some of the exciting parts of this program. So ready for any questions?
All right, thank you so much, Stacey, Ben and Sheena. I think that was a really interesting and exciting way to start our conference. Everyone will notice that there is a Q&A button at the bottom of their screen. Might be in a slightly different place if you're using a phone, but you should see the Q&A section. Tony, our moderator, Tony Schillerbeer, will go through those questions and put them to the panel. So please hit us up with some questions now, and our three experts from the HIT, I nearly said the HIT squad there, will absolutely be keen to answer them.
Stacey, I don't know whether you can see that question, but there was...
You might have to read it out.
Yeah, I can read it out. So there's a question from Amelia, who wants to know what the name of the risk assessment tool is that you use with each client interaction.
So it's the one that Sheena was talking about is the Drear assessment tool, but it is anchored on a number of different risk assessment tools. So when somebody is considered for an extended supervision order, they're generally deemed a violent offender or a sex offender. And we also have domestic violence offenders. Our risk assessment tool that we use for our violent offenders is the Violence Risk Scale, the VRS, by Stephen Wong. So everyone will have a VRS full completed for them, and we will be referring to that assessment tool in order to feed into what their level of risk is. For our sexual offender cohort, in the last couple of years in South Australia, we've moved to the VRSSO. We used to use the stable assessment tool, but we are using the VRSSO, so Violence Risk Scale for sexual offenders, which is also by Stephen Wong. In terms of our domestic violence cohort, we use the ODARA, and this is going to test me, the Ontario Domestic Abuse, yes, and a few other things. Apologies, I can't remember off the top of my head. That assessment tool isn't a dynamic assessment tool. It is a good indicator where there is risk of domestic violence, but it's not as helpful as what the VRS and the VRSSO are for us. So we're using those as the core risk assessment tool for those clients. What we then use when we're working with clients in community is the Drear risk assessment tool. Now it's got 3 scales. There's a stable scale, which looks at risk factors that remain relatively stable over a period of years. Then we have an acute subscale, which is really looking at acute risk factors that can change like daily or weekly. And then we've also got an area for strengths or protective factors as well, and they can be reviewed on a weekly or fortnightly or monthly or daily basis. And so those stable risk factors that we're looking at in the HIT program don't tend to change, but we are constantly reassessing those acute risk factors and somewhat the protective factors, but definitely those acute factors. They're things like housing, aggression towards case manager, substance use, and they're the ones that we're really mindful when someone is starting to become a bit wobbly, is what we say. They're starting to become a bit wobbly. We're really thinking about those acute risk assessment items as an indicator of whether or not a return to custody is required. We do have lots of non-compliance with orders, and I suppose what we're trying to do is hold that risk as much as possible and try and work out other ways to reduce the risk in a safe way. But when the risk is too high, we return to custody, but we do try as much as possible to try other interventions and to hold that risk to try and reduce it before a return to custody occurs. But sometimes it just happens really quickly and return to custody is the only option.
Thank you, Stacey. There was a question, I think, about the ODARA, and it's ODARA is the acronym for it.
That's correct. It's used throughout all areas of the department, and I know it's quite widely used by police. Whilst it is, as I said, a good indicator of those who are at high risk of domestic violence offending, we don't find it particularly, it's quite short, it's a bit of a screener, and so it's not so helpful when we're trying to flesh out our dynamic risk factors.
And I've just jumped on my friend Google, and it's the Ontario Domestic Assault Risk Assessment, and if anyone wanted to jump onto Google, there is an easy link there. Now, I've got a hand up from the conference room in Queensland. If you can unmute your mic, you can feel free to ask the question.
Thanks, Penny. I was just wondering, do we have much feedback from the participants themselves in this program?
I think the question was, do we have any feedback from the participants?
Yes, thanks.
I can do it.
Yeah.
Yeah, it's been pretty widespread positive feedback from the participants, which probably isn't the usual metric for things succeeding, and probably not what the public are really that interested in terms of whether the participants really like it, but they actually are reporting very consistently that it's a different approach than what they're used to. They're reporting that they can trust the case managers and the clinicians quite a lot more than they have in terms of their previous interactions with corrections, both in custody and in community. There's, as we spoke to earlier, really kind of anti-social and anti-system, anti-DCS kind of attitudes, which are really widespread. And I think we're kind of breaking that down, and we're showing them that we're working with them in a different kind of way. Invariably, when we do have to kind of breach them, or there are those returns to custody, there's a bit of a rupture there. But interestingly, I think we're finding generally as well that we're able to kind of repair those ruptures quite quickly and continue to work with people. Most of the people have, I think there's only been one person who refused to go onto the program initially. And I don't think anyone's exited the program because they haven't liked how we've been working with them.
Mm.
And I'll just back on to what Ben was saying about the feedback from the clients. For myself, who was already a case manager in community corrections, some of the clients I was assigned through the HIT program, I'd previously worked with in community corrections as a senior case manager. And so for them, probably the feedback that we've received is that they can see how this is a very different model, and that there's a lot more benefit to them through engaging with this model. And so a lot of those clients that I've previously supervised have said to me how they can really notice a difference in the way that we're working with them, and that it probably took them, those individual clients, a little bit of time to understand that this was a different way that we were working, and because it was a familiar face who was taking on their case management under this program, it was probably a little bit confusing for them initially, but very quickly they could see that this was a very different way of operating. And all of those clients have expressed how this has been extremely beneficial to them, and they can see how this is working in a very different manner.
And I'm sorry, just to add to that as well, I think one of the things that we have really as a group wanted to ensure in our interactions with clients that we're really working within an attachment theory framework where we're really conscious of trying to build a safe and secure attachment with our clients, and that's, you know, case manager, clinician and Aboriginal specialist. And also just, again, that trauma-informed response, acknowledging the, you know, if not most, if not all of our clients have a really profound history of trauma. And so we do keep that in the forefront of our work with our clients and acknowledge that those experiences that they've had, we might not always directly treat the trauma, but we absolutely operate in a trauma-informed way.
Thank you. There's a few questions online, and I'm just aware that we've got 10 minutes. And Erica, I wonder whether you might be able to put up the contact details for the HIT team as well on that last slide. So if there are any questions we don't get to, people can just email the HIT team direct. So the first question, Stacey, is what was the name of the DV assessment tool that you're using? I think this question's from WA. WA have commenced using something called the DVSIR.
We're using the Drear assessment tool for all clients in the HIT program, regardless of what their offending profile is. So it's the Drear assessment tool. But we'd love to hear about that assessment tool and how you're finding that implementation. We do have overall less people in our ESO cohort that have received their order purely for domestic violence offending, and that comes down to some interesting wording within the legislation where you are deemed a high risk offender because you're at appreciable risk to community. And there's some interesting debates that happen in our Supreme Court about community, and is that one person, i.e. an intimate partner, or is that the wider, you know, community? So we don't actually see domestic violence offenders alone, you know, receive an extended supervision orders, but most, as you would imagine, our cohort who have generalized violence, sexual offending, also have domestic violence offending, which for us is a huge focus because we are very conscious of the harm that can be the harm to intimate partners and the really high risk that our clients can present to in families.
Thank you, Stacey. And there was a question about how Drear acronym is spelled. It's DRAOR.
Correct.
And that will also be pretty readily available on our friend Google.
Yes, sorry, just on the Drear quickly, again, Google, but we did we received some training through Corrections Victoria. Corrections Victoria use their Drear assessments with their parolees as well as their post-sentence supervision. And then it's probably people from Victoria online, but we very much got some help and lots of assistance from Corrections Victoria with that assessment tool.
Thank you, Stacey. Another question online. To date, has the HIT team seen any successful completion of any offenders on ESOs? And will the team be tracking these offenders post-order to determine if they've returned to the justice system or maintained learned interventions?
So as of today, 3 of our clients have come to the end of their orders. So we've supported them to the end of their order. We do have a team of staff within our program services unit who are conducting the evaluation framework, who will be tracking clients in our program and tracking clients who may have been considered for our program but not recruited or admitted into our program. They will be tracked for around 6 years generally, to look at whether or not they've come back into contact with the justice system. But that data will be mostly criminogenic data that's pulled from our justice system information, or potentially through health records at emergency departments. We won't be interviewing them post the order, but we will be doing a lot of that work before their order finishes, to ensure that when we're transitioning them from our program and back to community, that we're gathering some information about how they progress through the order. But what's interesting when you think about the evaluation framework is that this isn't a randomized controlled trial. We haven't randomly assigned people into this program. We have really cherry-picked the most complex, high-risk clients, and I'm not convinced that we actually have a meaningful comparative sample within the extended supervision order cohort in order to compare HIT program clients with supervision as per usual. We probably will end up getting a lot of our evaluation in terms of pre and post measures for the clients in the HIT program. So assessing them as they're coming in and assessing them as they're exiting, and seeing whether or not they've improved in different ways. But again, also tracking them for 6 years to see whether or not they'll be returning to custody.
Thank you, Stacey. And we might take one more question, bearing in mind we've just got a few minutes left before our morning tea. So case management role sounds a bit like an outreach role, which is great. Has there been any pushback from other staff or concerns from the agency about the approach? For example, safety expectations on other team members when case managers on leave?
Talk through that.
Did you?
Yeah. It's something that we've been very mindful in terms of that assertive, proactive approach, like the questions suggesting, you know, going out and working with clients in their own environment, working with families. We were very conscious that that was, you know, that we're working with high risk offenders and people with complex needs. So we have a number of safety measures that were really well thought out in the initial phases. There's a lot of consultation that occurs, particularly with my oversight, when contact is occurring outside of the office, at a home visit, that we generally try to have 2 people there, and we have very strict processes in terms of staff safety. Sometimes people will meet clients one-on-one, and that's when we've developed a relationship with the client where we're happy that the client's traveling well, that there's checks when when the staff member gets to the place, and when they're finished. We're also investigating duress alarms for staff as well when they're outside of the office as well. So the staff safety component is, I believe, robust, and staff only do what they feel comfortable with, and a lot of it is checking in with how clients are travelling and what level of rapport there is. In terms of what that looks like in terms of other case managers or what the requirements are, it probably doesn't get too much visibility at this point. That work that's happening off-site is not really visible to anyone other than the HIT program case manager and the client. And so we're careful not to set up unrealistic expectations for clients. Like sometimes we'll take a phone call on the weekend, but we don't want to set a precedent for that, because we're acknowledged that, you know, someone else might not be willing to do that. So we're I think there's not too much visibility in the sense that we're setting up an expectation for other staff, but I think there'll be something to be said about the proactive and assertive approach. I think it is been really a key component. And, you know, those times where we've stayed late with clients in crisis, I think there's something really good and there that I think we could, you know, really review at the end of our pilot and consider about our for our treatment as usual approach. We do some outreach within community corrections, but I think it's something that we could look at doing more of, because I think it's actually really, the clients really like it. And in fact, you know, a lot of the case managers or the staff in the team say, you know, this is the stuff that I wanted to do in my job, but I never got the time to do. So the staff are actually usually quite happy with that component of their job. They're you know, in the client's environment with them, like walking alongside them and supporting them shoulder to shoulder, rather than across each other in a community corrections office. So I think it's really positive, and I think we could look to do more of it.
Thank you. Well, our time is up now. So thank you very much, Stacey, Ben and Sheena. That was a very impressive and interesting presentation, and I'm sure it generated a lot of interest. As I said, your contact details are up on the screen. So if participants want to, you know, jot down those details, I'm sure Stacey and the team would be happy to take some questions offline. So back to you, Daniel.
Thanks, Tony. Thank you so much for moderating that discussion, and thank you once again to Stacey, Sheena and Ben on really enlightening us on what the HIT team, the HIT squad are doing down there in South Australia. So we are going to take a short 10-minute morning tea, and then we're going to come back. Many members from across the country reached out with their thoughts and prayers for Kerry and her family. She leaves behind 3 adult sons, of whom she was